Thank you for visiting our poster on Deprescribing Heart Failure Medications in Older People, a Systematic Review and Meta-Analysis. My name is Mai Duong. I'm a PhD candidate at the University of Sydney in Australia, and my fabulous research team and I are thrilled to present our preliminary data on our review. Heart failure is on the rise and is associated with high mortality and morbidity, particularly in those over the age of 75 years. Most people living in the community with heart failure are frail, and polypharmacy has become synonymous with heart failure due to the complex management of disease and comorbidities. Yet deprescribing guidance on implementation and safety remains unclear. So we want to determine the feasibility and clinical impacts of reducing the dose or ceasing heart failure medications in older people and evaluate these outcomes by frailty status. We conducted a systematic review according to PRISMA 2020 checklists and registered this in Prospero and validated a search and came up with around 4,700 studies from electronic databases, registry citations, and websites. We screened and assessed strict eligibility criteria and included 27 studies, which included 5 randomized controlled trials with about 500 participants and 22 observational studies of around 413,000 participants. We looked at feasibility, which we defined as the proportion of participants who ceased or reduced a heart failure medication and did not restart, which we considered successfully deprescribed the medication. We also wanted to know that clinical impacts, including mortality, hospitalization, and most frequently reported adverse drug withdrawal effects, for example, worsening heart failure. We also looked at frailty status. 2 independent reviewers screened, validated the extracted data, assess risk of bias and certainty of evidence using grade. If there was no substantial heterogeneity, then a meta-analysis was conducted on the outcomes, and meta-regression looked at the study level factors. If this was not possible, then we described the results in a narrative analysis. So no studies reported frailty status. And of the crossover studies where participants were their own control comparison group, no hospitalization or mortality was reported in up to 1 year follow-up, with exception of 1 death after deprescribing digoxin within 12 weeks. The randomized controlled trials did report for 3 drug classes. They looked at digoxin, diuretic, and ACE inhibitors. Then observational studies reported for a total of 6 drug classes. Here you can see in the graph for the proportion of feasibility, over 50% of older people with heart failure were able to cease their digoxin or reduce their ACE inhibitor with reduced mortality. However, this was also associated with increased hospitalization and worsening heart failure. Mortality, hospitalization, and worsening heart failure were reported with high certainty in digoxin and in beta blockers and less certain in other drug classes. Particularly with beta blockers, this was very heterogeneous sample, and it was often recruitment of very sick people who were there for acute decompensation in hospital. And of those that reported improved mortality and successful deprescribing of digoxin, there was less than 1% reporting of tachycardia and AFib. So we can see here the evidence is clear that we actually do need a lot more work and evidence to describe, to include clinical trials or different research methodologies to help guide appropriate deprescribing to help us understand how to balance the benefit and the harm of continuing medications and changing patient priorities. So thank you for listening to our poster and visiting, and we wish you a great conference. Have a great day, and please reach out to us with any questions or comments. Take care.